डॉक्टर आतिश बकाणे जॉईन झाले का? दिसले नाही.
मैम प्लीज स्टार्ट.
नहीं, ग्रविता ये डॉक्टर बकाणे जॉईन हुए की नहीं?
I'll just check, sir.
मैं फोन करता.
हाँ,
ग्रेविता
तब
मैम
तक देन
चालू करो.
you start.
Learning is not attained by chance. It must be sought for with ardor and diligence. We at the Maha AP, Maharashtra Academy of Pediatrics, proudly launch our first episode of new series of academics in the year 2024. Tips to office practice. जैसे चाय पे चर्चा हो, वैसे tips to office practice from our experts here. I welcome Dr. Ram Gopal Chijera sir, President Maha AP, and Dr. Amol Pawar sir, Secretary General Maha AP, to just give a brief view on this new topic.
Good evening, friends. As Dr. Gravita said, we would be launching a lot of programs. Still 2-3 are pending. So this is a first episode of tips in office pediatric practice. For I welcome our today's guest of honor, Dr. Atul Kulkarni, our Vice President West Zone. Then our today's expert, Dr. Ratna Sharma and Dr. Atish Bakane. See, today we would be covering two topics, that is neonatal jaundice, particularly approach to a G6PD deficiency, and ABC of CBC in office practice. Welcome to both the moderators for today, Dr. Gravita and Dr. Praveen Gokhale. I will not take much time. We have to start as early as possible. So over to you, Gravita.
Thank you, Ram sir. First of all, welcome all both the experts. Then today's MMC observer, Dr. Vaibhav Pustake sir, who happens to be senior pediatrician from Pimpalgaon, Nasik, the Grape City, and he was also past secretary of Maharashtra IIP. Then today's guest of honor, Dr. Atul Kulkarni sir, Vice President West Zone. Then both the moderators, Gravita ma'am and Praveen Gokhale sir, and all the office bearers of Maharashtra IIP branches and EBs of Maharashtra IIP, and also all delegates and PG students. This is an innovative program.
Madam, unmute karana, please.
With which all the pediatricians, common pediatricians at peripheries and district places and cities also, they will get to learn many tips in their tips which will be useful for their office practice also. So without wasting time, I once again welcome Dr. Atul Kulkarni sir and ask him to give his welcome speech, his address to the gathering.
Yes. Thank you, Dr. Amor, for inviting me for this program. Actually, this is a program from my Maharashtra only. Actually, this is a great pleasure to be here on the Maha Academy of Pediatric virtual platform. And our president, respected my friend Dr. Ram Gopal, Secretary Amol, I call him as the powerhouse of Maharashtra because he is always energetic to do all the programs and all the activities. Then Dr. Bhavesh, who is the scientific convener of this program, and other EVs from the Maharashtra, Dr. Sanjay. Today's experts, Dr. Ratna Sharma madam and Dr. Atish, and moderators, Dr. Gravita and Dr. Praveen, and all the delegates. If you see this year 2024, the academic activities are started like a boom in all over India under the leadership of Dr. Basavaraja. Already all national modules DOTs are over. Zonal TOTs are also over. Modules are already started in the peripheries, also in the districts, branches, and other programs like academics with institution, IIP ki baat with community ke saath. all these programs are started. And I am really proud to say that our Maharashtra is not still it is at par with the central IIP, and under the leadership of Dr. Ram Gopal, we are doing a wonderful job. We are getting the reports from all the districts everywhere. The programs are conducted very nicely, and just now we have received many reports from the district branches. And routine, along with the routine, today we are Dr. Ram Gopal and his team. They are launching a new topic, a new series, that is tips in the office practice. I really like this topic because this is going to be useful for each and every pediatrician, and we are taking probably all the specialties and super specialties, and today we are having hematology experts with us. So best wishes for this program. Thank you so much.
Thank you,
Atul sir, for your
Thank you,
encouraging
Atul.
words.
Thank you, Atul sir. Now we'll have words of wisdom from Dr. Vaibhav Pustake sir, who happens to be MMC observer for today's webinar. Vaibhav sir.
Sir, unmute please. Vaibhav sir, please unmute.
Please unmute sir. Sir, Vaibhav
Yes,
sir,
yes.
unmute kar.
Yes. Am I audible?
Yes, sir.
Right. Now we've already 10 minutes late, I suppose. The tips for the office practice is a very good initiative which has been taken by the Maha IAP, and I would not waste much of the time, and I'll ask you to start the program immediately.
Thank you, Vaibhav sir. Now, Grivita ma'am, please take over.
Thank you, sir. Thank you so much. So we have our expert for today, Dr. Ratna Sharma. Madam is a senior pediatric hemato-oncologist at Jupiter Hospital, Thane, and the CHC PHO BMT Center, Borivali, Mumbai. So should we just start? Should I share my screen?
Yes. Yeah. You share your
Madam
screen.
Kashmiri, you may stop sharing, please. Is my screen visible?
Yeah.
So to begin with, we have this case one, a male term newborn born by LSCS, birth weight of 3.6 kgs, born by third degree consanguineous marriage to a Bohri Muslim family who are migrants from Gujarat, who are migrants from Sindh. On routine G6PD screening of cord blood sample was 3.6 units per grams of hemoglobin. Mother's blood group was B positive, baby O positive, AB positive with no setup. On examination, there was no cephalhematoma noted, and TSH was within normal limits. At 36 hours of life, baby developed icterus, was noted to be in intermediate risk zone with a value of total serum bilirubin of 12.5, and hence single surface phototherapy was started. At 48 hours of life, it rose to 17.1 and with an indirect value of 16.5, hence DSPT was started. The phototherapy continued for 6 days for another until day 4 of life, and finally stopped at a value of 9.3, and DSPT was stopped. So my first question is, how early can a newborn with G6PD deficiency present with neonatal hyperbilirubinemia? Dr. Ratna?
So Gravita, what we have seen usually is that the babies with G6PD deficiency usually present with hyperbilirubinemia rising, after 48 hours of life. So this is after ruling out all other causes. So if you have a report of G6PD deficiency in a baby, that does not mean that the hyperbilirubinemia that is happening is because of hemolysis. You have to look for the other causes as well, especially in the first few days of life. Breastfeeding jaundice has to be, taken into consideration. Once you have ruled out all the other causes and you are seeing a picture of hemolysis on peripheral smear, drop in HB to some extent with reticulocytosis coming up, that is the time when we say that the bilirubin is rising because of G6PD and hemolysis.
This particular baby, the reticulocyte count was around was 5. Hemolysis was active. Hemolysis was not seen on the peripheral smear. Could we still label it as a neonatal hyperbilirubinemia with
No,
G6PD
looking at
deficiency?
Yeah, looking at the trend, it could be partly due to breastfeeding in the early part with physiological jaundice overlapping, which did set in a little early, but with no drop in HB, we could still consider this to be a part of physiological, and give phototherapy and deal with it accordingly. So for me
What
as a hematologist, a peripheral smear would be important. Other evidence of hemolysis like or raised LDH would be important. The picture of peripheral smear is very classical in G6PD. So if we see that, then we really know that what we are dealing with now is the onset of hemolysis because of G6PD deficiency.
we don't have a picture of the hemolytic picture here, but ma'am, could you just elaborate a little bit on what may be seen on a peripheral smear?
So we see reticulocytosis, normoblasts may come into picture, bite cells, host cells, and blister cells. They are very classical. So typical apple bite picture of RBCs is visible. And then we look at the picture, we see the drop in HB, a rising retic, a little bit of LDH elevation. All this is evidence of hemolysis. If possible, you can do haptoglobin levels also, which tells you about intravascular hemolysis and release of heme.
Well noted, ma'am. So the inheritance pattern in G6PD is X-linked. So I suppose only males would be the ones who would be sufferers. Hemolysis occurs in only males. So do females also manifest hemolysis? If yes, what is the incidence?
So being an X-linked recessive disease, obviously males are predisposed to having G6PD deficiency, as we all know. A mother who's a carrier marries a male who is G6PD deficient. You can have females who could be homozygous or compound heterozygous for given mutations of G6PD. And you could have female babies also landing up with, problems during the neonatal period. So when you have a picture like this in a female newborn, you would definitely check the mother for the carrier status and father for affected state.
So moving on further, this was a
Even
report of the
lionization, even lionization where you have inactive X chromosome of one type. So then in that case also you could have a female who's affected, which is rare. So we have had patients where they've had compound heterozygous females who are deficient, and this also is a rare scenario. But because G6PD is common in certain communities, and obviously marriages are happening predominantly still in the same communities, you could land up with a couple where the female is a carrier and a male is affected.
Moving on further, this is a report of the baby. Ma'am, maybe you please elaborate on may help us understand on the tests, the quantitative analysis, qualitative analysis. What exactly are we using in our day-to-day practices? Ma'am, may you please elaborate on this?
So it can vary from city to city and center to center. We did launch the newborn screening methods, where it was supposed to be a screening methodology, and it was definitely a qualitative assay at that time. Some of the centers now, if they have inbuilt lab where they are doing quantitative, assays, and they have deliveries happening within the hospital, then they may directly go in for quantitative assay even in newborns with cord blood sample. But as a policy for screening, we are still using qualitative assay in the community. The sensitivity is good of these tests, so we are okay with it. But only thing is, if it comes positive, then we recommend that they do undergo quantitative assays to confirm, because that is a confirmatory test by spectrophotometry method, where you have actual quantification of the G6PD enzyme, and that it is done as what you have shown over your units per gram of hemoglobin. So it does give an idea about the extent of deficiency, and then that is used as the final report for calling this patient G6PD deficient.
So the
So the
reference,
earlier method of qualitative, the dye decolorization method, is still being used in some places, and it is a reliable test. The screening methods have a sensitivity of 96%. The dye decolorization method has a sensitivity of almost close to 100%.
ma'am, the normal range, would it differ with the labs? Or is
No,
it
the
subpar? Is it
quantification, no, after a lot of studies, quantification of G6PD has been, put up as what is the expected normal range. In fact, in newborns, the expected normal range is even higher. But to call it deficient, there are cutoffs which have been, laid down, and anything less than normal, the lab alerts you. But the report could be as low as 2.2. So anything less than 2.2, they say ki definitely this baby is deficient and is can have manifestations. But anything below the normal, some labs have a cutoff of 8. It depends on the kit also what you're using. But quantification by the standard criteria that are given to call a patient G6PD deficient is around 7.5.
Thank you. So moving on further, in case of active hemolysis, if we draw blood for assessment, will the value be true, false, high, or false, low? I mean, would the value alter in case of active hemolysis?
So I think by now, like everyone, we have been talking about it, that when you check for G6PD or quantitative test or the qualitative test during a state of acute hemolysis, especially in newborns, you may get falsely high report, which may mask the actual deficiency state. It could be low normal or little lower than the acceptable normal limits, and you may be, you may tend to call it that this patient doesn't have G6PD deficiency. But if your clinical picture fits into what is happening to the patient is suggestive of G6PD deficiency, then it's worth repeating it after some time. Manage the patient, repeat it later. You may get a family history also, so that also helps you in making a diagnosis, or you could send the sample for mutation analysis.
By how many months to be repeated?
This is because the reticulocytes and the new RBCs that are being pushed into circulation may have normal G6PD, and therefore the population of RBCs that you're looking at, it will not reflect the actual G6PD levels. So you could go wrong in actually quantifying at that point of.
And when do we repeat it? After how many months or days?
So it's preferable to repeat it after 3 months. And now with mutation studies available, you can send it directly for finger sequencing a sample. Whenever there is data.
We do the heel prick test for newborn screening program, which is convenient and done in many of the hospitals. Which is the method used for testing, and how reliable is it?
So this is actually a ring method which they are using with blot paper. That method is approved by WHO. It can be used, and that is what is being used by those who are picking up samples, by heel prick on a blot paper. And that is what I was mentioning, that it has a sensitivity of 96%. It is a good method of mass screening program. So if it is positive by that, it has to be confirmed by your quantification method.
A word on genetic assessment of G6PD by molecular diagnosis.
So genetic assessment is not mandatory. Quantification tells you definitely that this patient is deficient for reasons of knowing what is the genotype in our population, what type of variants we are dealing with. It is always welcome to do the genetic analysis. There are certain genetic variants which do have severe manifestations. We in India see basically the Mediterranean variant. We have our own country variants like the Orissa and the Mahadol variants. So there has been some phenotypic correlation attached to these genotypes, and we all know that all G6PD patients don't behave similarly. So there is a severity could be based on the percentage of enzyme deficiency also. It could also be responsible. We know that certain variants do behave with absolutely no G6PD in them. So they are really severe types. And these patients can be, family can be prepared to deal with it. That is the only help. And it does help in surveying our own country, what we are dealing with in our own country as variants. There are papers published where they have talked of around 12 variants which have been reported in our country. All over the world, there are about more than 200 mutations already. So in future, with these tests available, I think there is no harm in asking a family to do it if they can afford it.
So it is more of a statistical relevance.
And also it may help an individual patient. We definitely do it in those who present with chronic hemolysis like picture in G6PD deficiency, or who present with frequent intermittent hemolysis, then it would be interesting to know, and we can guide the family accordingly.
So would it be?
So there is a role for it.
So would it be useful for planning on any further pregnancies? Would that be helpful?
So prenatal testing for G6PD is not being advocated because the phenotype that we are seeing in our country is manageable with the prevention of the agents which can cause hemolysis by dealing with hemolysis on time. So currently, we are not advocating any prenatal testing for G6PD deficient. If first of all we are not supposed to be revealing the gender, so it's going to be a testing done for a gender which we don't even know whether it's going to be a male baby or a female baby. So even if we know if the mother is carrier, we don't advocate prenatal testing in G for suspected G6PD.
Coming up to a very important question, do we give vitamin K in this situation? And if yes, is it K1? And how safely can we give vitamin K1 to all the newborns at birth?
So, as a policy, vitamin K has to be given as early as possible after birth, even before the baby is given for feeding to the mother, right? And within 6 hours, definitely as per the rules and regulations or recommendations that are there for giving vitamin K. G6PD report turnaround time, even if you said cord blood sample by any method, it would take some time. There are methods where they give you a report within 2 hours. Also, if the lab is within the hospital, but we do never wait for the report of G6PD to give vitamin K as a rule. And though vitamin K is known to be associated with hemolysis in G6PD, the incidence is very, very less. We have not encountered anyone. We remain alert once we get a report of G6PD deficiency after having given vitamin K already, as is the policy, but never encountered a scenario where we could attribute the severe hemolysis or significant hemolysis to vitamin K. Obviously, the cases which land up in new NICU for phototherapy would have also received vitamin K. We don't have a way to prove whether they would have not had this hemolysis if they wouldn't have been given vitamin K. And it's manageable, hyperbilirubinemia. So there is no way I can suggest that vitamin K should not be given. It is a tedious thing to handle a neonate with bleeding manifestation as compared to a neonate with hemolysis. It can be managed, I would say, if picked up at the right time, given phototherapy, if required, even if there is a drop in hemoglobin and you need to give, transfusion or an exchange transfusion, all that can be managed.
So I can safely give vitamin K1 to all the normal newborns within at birth.
Yes.
So this baby was started on intensive phototherapy for 4 days and discharged by the 6th day of life. No rebound hyperbilirubinemia after 48 hours of follow-up. Now, what advice would you give at follow-up?
So generally, all babies who are picked up as G6PD deficient, during in the newborn screen program, whether they land up with hyperbilirubinemia requiring phototherapy or not, all of them on discharge are given the same advice that the offending agents have to be avoided. Mothers do get anxious about it because even the family screen, and the mother comes to know that she's carrier. So counseling is important. Screening of other male members on the maternal side is important. We tend to pick up, family members who were never aware that they were G6PD deficient. So counseling is an important thing. Genetic screening, if possible, we advise them if you want to do it, they can go ahead and do it, but quantitative tests for all the male relatives on the maternal side. Offending agent, there is a list available. They only come and ask us questions whether they can give this or that. But we tell them not to get too anxious. Routine parenting. The doctors whom they visit would have a list wherever they visit, which medicines should not be given, where it is necessary to give certain medications. Obviously, most of the doctors, physicians, and pediatricians are all aware that they need to be alert if they're giving something which needs to be given despite, it being known to be causing hemolysis in G6PD deficient patient, and we are on alert. And in case of food, the dietary advice in the Indian population is we have not come across anything specific. There is a list of things given, especially Chinese herbs and fava beans. We all know, which are currently not the routine diet for Indian population. Though we have people traveling abroad, and you have all types of food available in our own country. So we tell them to check for these things and obviously avoid fava beans even if they encounter food which is to be having it. So that is one warning we give them. There are a lot of food items which have been listed, but correlation, there are reports, but definitive correlation is yet to be established for most of the things that are listed as food items causing
So these
hemolysis.
foods which have been mentioned here, do they be avoided, or
We tell them, see, every patient is not going to hemolyze with exposure to all these foods, and the quantity of food also matters. So, when the child is young, first 5 years of life, when the weight is less and the consumption of food may be as much as what the adult takes in, then we say that the oxidative damage could be more, and therefore they present with hemolysis. As they grow, the quantity of food proportionate to their body weight, we have not encountered 1:1 correlation with any of the food items. And if they know of an offending agent, obviously they avoid it later. So the
any
mothers
correlation
come up with the list,
mother's
which is longer
breastfeeding?
than ours sometimes.
If the mother is breastfeeding and consuming any of these substances, would it harm the baby or anything? Any
Yes,
reports?
it can have breastfeeding. All that can cause G6PD hemolysis if it is consumed by the mother and if it passes through the breast milk. Obviously, the newborn is likely to have impact.
Okay. Any herbs or anything in specific which you would like to highlight on, or it's not nothing is clear as yet?
Revita, no, we have been, trying to look for all possible causes in the mother's, diet when we have a newborn with G6PD, because the stress factors of, going through the birth canal itself, or there are multiple reasons they have trying to find out why a newborn would have, hemolysis. But when the hemolysis continues, then we definitely look for things like we're using clothing which is, with naphthalene balls, or mother having something which is precipitating hemolysis. So these common things have to be looked for. We have looked at certain ayurvedic things also which the mothers consume for increasing breast milk, but never found a specific offending agent. And if you look at the list of contents, we try to search with every content but we have never got any specific correlation. Some preservatives we had found, but it is difficult to say that they're going to be responsible for hemolysis in every baby whose mother is consuming this. So it would not be fair to actually put it up as the cause for hemolysis.
Any food substances are definitive causing hemolysis? Anything as a relative contraindication, or relative contraindication or an absolute contraindication to drugs or anything like that, or it's
So
we just give the chart
fava
and that's
beans, yeah, fava beans, blueberries, for adults, red wine. So all these things have been, documented in high number. So their correlation could be considered, yes, that it would be responsible. But the others, there is no study done specifically to say this is going to be causing. Chinese have done a lot of studies with Chinese herbs, but then we are not using them.
So we could, when we have a lot of Chinese food, we have to be a little bit careful, maybe.
So Chinese food is not responsible. Nothing in the Chinese food has been found.
Now a
And
word on this.
incidentally, none of the Chinese variants of G6PD have crossed the borders and have been found in India. Incidentally. So we have the Mediterranean, but we don't have the Chinese variant at all so far. I mean, we have not picked up in the studies that have been done by ICMR.
Moving on further, ma'am, may you please elaborate on this, the WHO classification for G6PD deficiency, and why is it important as a lay pediatrician for us to know about this?
So this only helps, this is based on severity of manifestations, based on the enzyme activity. And we are lucky that we see class 2 and class 3 with the Mediterranean type that we have in our country, including the Orissa type that we have and the Mahidol type. They all are in the class 2 and class 3. Patients may remain asymptomatic. The family members sometimes are asymptomatic. So their enzyme activity could be actually, if you look at the content, other levels, they could be low, but they don't manifest. So we see a very varying population. And they would say that I've eaten all that, I've taken medicines also which are known to cause hemolysis, but I've never had, So we have a very diverse phenotype of G6PD. We are only worried about the ones that have chronic hemolysis. The percentage is very less. We don't see a huge number of them. And we are worried about those who are coming frequently with intermittent hemolysis with any minimal stress. So that becomes very challenging for the family, which also the number is very less. And once you know the offending agent, sometimes you can deal with it. And early reporting during febrile illnesses becomes very important. Starting antibiotics on time is also going to be important for these patients.
So moving on further to the next case, we have a preterm male born to a G3P1L1A1 at 31.4 weeks by LSCS with a birth weight of 1.69 kgs. Otherwise, the course regarding the prematurity was uneventful. The baby was shifted by mother's side by day 2 of life. Mother's blood group was A positive, baby's was O positive, DCT, ICT negative. Now, again on cord blood sampling, we got a G6PD deficiency report. Deficiency was noted with a report of 1.17 units per grams of hemoglobin by the quantitative method. This baby developed icterus at the 64th hour of life. This was at 64 hour of life, the serum bilirubin was 12.95 with the HB of 16.2. Double surface phototherapy was started, which was settled by 88 hours of life, hence shifted again by mother's side. Noted to again have on day 5 of life developing a bilirubin value of 14.6. Again DSPT started, and day 7 of life baby was discharged with a word to follow up after 48 hours. This baby, the story continues. This baby comes again on 9th day of life with a total bilirubin value of 22.43 and started on triple surface phototherapy. And the story continues, and there is evidence seen on day 13 of life. There is a drop of hemoglobin with an increase in the reticulocyte count, and the baby, so much so that the baby required a triple surface phototherapy with even PRVC administration with PAX cell administration required. The baby continued on intensive phototherapy, finally requiring 4 aliquots of PRVC, and finally discharged on day 22 of life. Now, how late is hemolysis expected in a case or to continue in a case of G6PD deficiency? This was something unusual, right?
Yeah, so we do encounter such patients, on UNIs, less in numbers, but definitely we encounter such patients. The first phase of the jaundice still could have been, a breastfeeding jaundice. We don't know, means unless the hemoglobin has dropped. I've not seen the smear, so we don't know about the first phase of jaundice. Second phase of jaundice, where the red tick definitely jumped and the hemoglobin started declining, could mean that there was an onset of G6PD deficiency associated hemolysis. And when it triggers, you could have all types of babies. Those who settle down, within 3 or 4 days, and those where the hemolysis can continue. It all depends on the percentage of RBCs that are going to get hemolyzed. So we have had patients where the hemoglobin has, you come to know that the turnaround of all the RBCs actually hemolyzed over a period of time. The patient dropped the hemoglobin dropped gradually. We ended up giving transfusion. So if the percentage is very, very less, and most of the RBCs are going to be carrying less G6PD within them, they are likely to hemolyze, and we may end up actually doing an exchange transfusion if the phototherapy is not working because the bilirubin is rising, or if the phototherapy is as effective enough not to require an exchange transfusion but the hemoglobin drops, then we end up giving them transfusion. So it can go on to 2 to 3 weeks. It can go.
3 weeks. Ma'am, in this particular case, do we look for something else? Do we think of something else like any maternal drugs or any?
No, one thing is that you have to always look for any other cause also. Having just a G6PD report, as I told you, does not mean so. There has to be evidence on peripheral smear, and you rule out all other causes. Yeah, as I told you in the first case also, if the hemolysis is continuing, you have to look for, a dietary history of mother is important. Any other offending agent, like, the clothing and all is important. We have to take care of all that. The use of naphthalene balls has gone down, at least in the urban areas. I don't encounter many patients or mothers, using clothes for children or babies with naphthalene balls kept.
So the next question is already discussed. How can we predict how this baby would behave in future?
Very, very difficult to predict, but definitely if it was a challenging case to begin with in the newborn period. Obviously our antennas go up and we are going to be alert and counsel the parent accordingly that the risk of hemolysis probably is going to be a little higher. And though it is not it's not going to be certain. You may have babies who presented in the neonatal period with hyperbilirubinemia and never had problems later. So difficult to predict. Doing a genotype in such a case, I would prefer to do a genotype in such a case because it's been, a significant hemolysis and the parents are going to be apprehensive. So it's good to know which type it is. So it may not, as I told you, exactly correlate.
Gravita, 5 more minutes.
Yes, sir. Just last question. What to advise and what warning signs would the mother be advised to observe on in this particular, I mean, in
So
any case of
sudden icterus, collected urine with any medication that is being given by a doctor, or with a febrile illness, or with any food intake which was unusual, where they went out to eat something unusual cooked at home, they should come immediately to the doctor.
So the take-home messages are early intervention by screening for G6PD is definitely helpful to prevent complications. Parent education and counseling is helpful. Quantitative analysis is the key to diagnosis. Molecular studies may help to understand the phenotypic variants, and vitamin K1 should be given to every newborn irrespective of the G6PD status. Thank you. I stopped sharing. Maybe I think we have some audience questions here. Dr.
I think
Sanjeev
Dr.
Joshi,
Bhavesh
sir.
and Dr. Sanjeev has
Yeah,
also
Dr.
raised their
Sanjeev
hand.
Joshi, sir. Sir, may you please unmute yourself and ask the question?
Dr. Ratna and Dr. Gravita, very interesting discussion, very pertinent to a practicing pediatrician regarding G6PD. I just have a quick comments that when G6PD present, or my question to Dr. Ratna may be, when the kids present beyond neonatal age as a G6PD deficient, they may have chronic hemolysis ongoing. And recently, I had a 5-year-old who presented with severe hemolysis, HB of 3.8, hypoxic encephalopathy, severe hemoglobin urea, shock, transaminitis. Indirect bilirubin was almost 13, direct was 1.5, and never investigated before, had a hepatosplenomegaly, no other evidence. We excluded hemoglobinopathy, no consanguineous marriage, and we managed that acute hemolysis part, but I was sure G6PD was same. And as Dr. Ratna has already discussed, in acute hemolysis, it may come to falsely normal. Okay, so the G6PD came normal in this child, but ultimately, my first the my first DD was G6PD only. Of course, we did DCT also, which came negative. Well, retrospectively, I looked at a 1.5-year-old toddler who was in the lap of the mother. So I examined him on the day 3 of the elder brother's hospitalization. He also had hepatosplenomegaly. He looks pale. So immediately his samples were sent, and that younger one was G6PD deficient, markedly deficient, only 3 milligram. So my point was, whenever you have an acute hemolysis, G6PD values may be fictitious. You have to repeat them. And in spite of asking so many leading questions in the history about drug, about febrile illness, about some unusual food, there was no history. So whatever we were discussing, that only Chinese food are the offending agent, there might be something in the Indian food also. And which particular category of phenotype or genotype you place this both these kids, Madam Ratna? One is 5-year-old, another is 1.5-year-old. The only significant past history was at the age of 1 year, one of the pediatrician has diagnosed anemia to that 5-year-old, and he was given some iron supplement.
So out of the general prevalence of G6PD that is mentioned, 1% of these can present the way you have had these two patients who have been into chronic hemolysis, have had a spleen which is enlarged, have been always icteric, probably, low-grade icterus. So these type of patients are known, and they would be categorized as severe because their enzyme activity is definitely much lower. It would be less than 1%. So they are at risk of hemolysis anytime. Only thing is they may land up with a acute hemolysis and present to the doctor. They may never reach a doctor with the chronic hemolysis ongoing unless, pediatrician actually picks up. So being alert about splenomegaly, mild icterus, working up the patient. Commonest enzymopathy is G6PD, and now with newborn screening, they are being picked up. But if the newborn screening has not been done, obviously the patients are still going to the pediatrician, then I'm sure all of them are alert to pick up these findings and, run a G6PD test.
So one more interesting phenomenon about with the G6PD has happened, that most of the diseases, the etiologies are increasing, but G6PD is the only condition where we are decreasing the list of offending drug. What is your comment, and what is the safest anti-malarial in a child with malaria and non-G6PD deficient?
So when you have a G6PD deficiency known and you have a child with malaria, you have to be prepared that you will give the ones which are safe and still watch for hemolysis, because nothing is absolutely safe in the list of anti-malarials.
Even
you have
WHO said the newer RT compound, they are also
those, because of the use of those drugs, obviously we are not seeing. But the rest of the all over the country, there are patients still being treated with standard drugs like chloroquine. So we have to know that we might land up with patients who have received primaquine for prophylaxis and landed up. Though we know that if G6PD is done before primaquine, the doses are going to be different.
But
And you still
chloroquine is
have to keep
surely
them
not in the
under
list.
observation. What's the
Chloroquine is
question?
definitely not in the list now.
No, it is still in the list. It is not out of the list.
Bhavesh sir,
Okay.
Yeah, a couple of questions on the G6 level. So if you go back to the first index case where the G6PD level was 3.6 unit per gram of hemoglobin. So how do we define the severity? Is this in a class 2 or a class 3? Also, the WHO mentions about the activity percentage, and in the grade 1 or a class 1, it is less than 1% of the activity, while in the class 5, it is more than 110 of activity. So I was wondering that if you have a more than 100% activity, how do you define as a deficiency?
No. More than 110 nahi hai.
If you go back to
the slide.
In the first one, we have not done only the activity levels, sir.
No, so that's a just
No.
So
His question is about classification. Just go back to the table of classification.
So the class 1 is less than 1%
It's
activity.
less than 10 with chronic hemolysis.
That is a class 2. Between 10 to 60 is a class 3. 60 to 90% is
1%. 60 to 90% is. Your voice is cracking, Dr. Bhavesh. Vivita, can you put up the chart which you had put earlier?
Yeah, 1 second.
So these classes, Dr. Bhavesh, were basically to look for those with a particular percentage and the phenotype. Chronic hemolysis, intermittent hemolysis with what percentage, and intermittent hemolysis with what percentage, and then 60 to 100 which have mild enzymes. So it is less than 1% of normal activity is chronic hemolysis. That's what. And they are also less than 1% of all the G6PD deficient patients. And
it does make 100%.
And less than 10, and severe enzyme deficiency less than 10% who come with intermittent, frequent hemolysis is class 2. With less frequent is class 3. They are between 10 and 60% of the activity. Now, what we are doing is quantitative estimation, and we believe that the quantity reflects the activity of what is taken as 100%. So some of the studies have taken 7.5 as 100%. And then they have tried to correlate it with the activity based on the quantity. So this is all based that we are assuming that the quantity is going to be 7.5, it is 100% activity. Got it?
So if I may ask Dr. Grivita to go back to the third or maybe fourth slide of the same case, where the index case was mentioning a 3.6 gram, 3.6 unit as a gram of HB. So this kind of is qualified as a 50% of activity?
Yes.
While the laboratory range is 6.4 to 20.
Yes. So that for the cutoff for percentage, they have taken 7.5 in most of the studies.
Okay. The next question is that many of these baby who requires to be given a blood transfusion And we also know that retic count will have a higher level of G6PD compared to the mature RBCs. So when we are
Yeah.
giving a transfusion, which will be obviously an adult blood, do we really need to check the collection date and the transfusion date? Because the longer we use the blood later we use the adult blood, it will have a lesser G6PD activity. Is that true?
Yes, it is. So for exchange transfusion, we always prefer to have whole blood, which is freshly collected, preferably, right? And there has been, questions about whether you're going to check the G6PD of the donor. So we have never ever, thought of that. We should be checking G6PD of a donor when
That
we're
was the next
actually
question.
giving a transfusion or exchange
But
transfusion
Bhavesh,
to a patient. So
Bhavesh, yes, yes.
Yeah,
Bhavesh, when you are transfusing that baby, the ultimate aim is to improve the hematocrit and not to
that,
improve the G6PD
and that
status of the child. Yes,
Uh,
Dr.
So
Ratna?
we need to hurry up.
you're going to infuse with RBCs which are having normal G6PD activity also. We always hope that also.
Yeah, yeah.
It's time up, sir. Maybe we could.
It's
So thank you, Ratna Sharma ma'am. Thank you, Bhavesh sir, Sanjeev Joshi sir. It was an excellent discussion. Moving on next, I call upon Dr. Praveen Gokhale sir to please come for the next presentation. I welcome Dr. Atish Bakane sir. Sir is a pediatric hemato-oncologist from Nagpur. Over to you, Praveen sir. May you please take over. Thank you, Kashmiri madam.
Good evening, everyone. We move to the second part of our presentation. I would like to share my screen is not getting shared.
Pallavi madam, may you please make sir the host as well?
He is already co-host, ma'am.
Okay.
When I am clicking on the tray, I'm not able to see my screen.
Sir, click on the share screen.
Yes, I did that. I'm seeing the layouts and options. I'm not able to see my own screen.
Your own screen.
That I'm not able to see.
Might be you have to rejoin again, sir. No, it's showing your window now.
Is it?
Yes, sir.
Yeah, now we can see your window.
See
Visible,
your
sir.
desktop. You can click on the presentation now.
One
There
second.
it is. ABC of. It's on the desktop, sir. ABC and CBC of.
One second.
Are you able to see your desktop, sir?
It is coming as a separate window. I'll just see. I'll click and then you let me know whether I'm doing
Definitely,
okay.
sir. Sure.
Is it expanding?
No.
It's visible now. It's
Yes, it
visible.
is visible.
You may please make it into a slideshow mode.
Yeah, definitely.
Yes, sir.
Is it
It's
full
full
screen
screen
now?
now. Yes, sir.
Yeah.
Thank you. Thank you.
Thanks a lot for assisting me.
Yes.
So I would like to, I have the pleasure of introducing Dr. Atish Bakane. Dr. Atish, are you there?
Yes, sir.
Yeah. So Atish is a well-known hemato-oncologist in the Vidarbha region. He has done his MBBS from Nagpur, DCH from KEM Hospital, DNB from Chennai. Then he has been with the pediatric hemato-oncology department at Gangaram Hospital, done an international transplantation course in Barcelona. So he has almost had the experience of all the geographies, and he brings in a lot of experience, including the first successful BMT for hemoglobinopathy in Vidarbha, and is a part of a team performing the largest series of SCD, sickle cell disease, bone marrow transplants in India. and is a senior consultant in the pediatric hemato-oncology at Ray of Hope Center of Excellence, New Era Group of Hospitals, and he was associated with the Indraprastha Apollo Hospital, New Delhi. So I think Dr. Atish, you have been a very diverse geographical area which you have been in your career. So with this, I will start with the ABC of CBC, because the CBC is one of the most common reports seen by pediatrician on any particular day. So I would really be interested in knowing when did this modern concept of CBC evolve and what encompasses the CBC? Dr. Atish.
Yeah, so thank you very much, sir, for that kind introduction. And in ABC of CBC, it's a huge topic. So whatever possible, we will try to cover, and the basics of mostly RBC morphology, like most of the pediatricians are well versed. Am I audible? I'm getting some.
Yes, you are
Yeah.
audible.
So and then we will talk more about WBCs rather than RBCs. So it is always better to know about our history, because as the history evolves, many things evolves. So it dates back to almost 17th century, when the this Anthony von Leeuwenhoek developed or invented microscope. That was the first thing, and then some could see that there are some particles in the microscope. They call them as some cells. So at that time, it was not very well known. Subsequently, Carl Weirot was one of the scientists who thought that these particles can be measured, and he tried to develop some hemocytometer that at that time he called. Subsequently, the stains, as we still use eosin and the other stains, those stains were discovered by none other than Romnowski. And still, all WBCs, platelets, all different types of WBCs are colored in different stains, and we can make them out in our microscopies because of Romnowski. And those stains came up. Subsequently, it was like 19th century, precisely I think first decade of 19th century, when some form of measurement or some first machine which could measure hematocrit was developed by a scientist named Otto Ellison. Subsequently, and after that, the most important, everybody's modern concept, modern machines which are dependent on impedance, electrical impedance, was developed invented by none other than Wallace Coulter in 1950s. Subsequently, that was dependent on electrical impedance. And so as the science evolved, flow cytometry, digital microscopy, AI-based techniques, digital microscope, and nowadays the recent cultures like Sysmex and Bickman culture, all these use these combined modalities. Whatever best for particular parameter, all these things are combined, and we get a very good CBC report. So nowadays we know, as there is a CBC from a very good. So most important thing what we should remember in such CBC is that whenever we read CBC and all the parameters, we should always get it confirmed that these are calibrated in that unit. For example, we will be discussing some indices subsequently. For example, immature platelet fraction. So nowadays we know it is important. Most of the people know, but whether it is really calibrated or not, because it can give very fallacious reasons. So with those things, yes, these automated analyzers are very good, and now we can almost make most of the diagnosis on our CBC report.
Dr.
So
Atish,
I think
many times we
yes,
have
please.
sent the CBC report, and like for a patient of maybe a fever, it may not matter because maybe they can follow up with the report in the evening time. But like in the previous case that we understood, like the case of maybe G6PD where you want certain parameters like hemoglobin to know. So how fast can these automated analysis based on the Coulter principle now get done with the report so that you
So
can be
very
well
fast,
connected to the lab?
it is very fast, so within 5 to 10 minutes, we get everything in hand. So such faster is the response time nowadays, because sometimes in our, particularly in hemato-oncology practice, we need some things very urgently. And these automated analyzers are so quick, and most of the times they are accurate.
So we have different type of analyzers. So Do they have differences in them? Like they measure a certain
Yes,
basic
I told you
parameters
there are a
and
lot of parameters, newer parameters are coming up. But most of the times, most of the this analyzers use 24 parameters, 5 color, 3 color, and if you go on like if you use flow cytometers later on, there are multiple colors nowadays, 8 colored. So most of the things are available. So but these things should be calibrated. That is the most important point.
so going on to the sorry, my slides are not advancing. So regarding A for anemia in the ABC of RBC, we generally refer to the most commonly read hemoglobin, normal, high. What really affects the hemoglobin and how should we interpret it in relation to the parameter of the measurement as well as the age and sex factors?
So I think this is most of the pediatricians must be knowing better than me. So we know these normal guidelines. There are different guidelines for the normal values. We know that males have a little bit higher side of hemoglobin compared to females, and particularly in adolescent females, hemoglobin may be less. So we usually follow WHO guidelines because most of the textbooks give a range. WHO has given us like the specific cutoff values rather than so that it's a ready reckoner that if for example if a child of like from 5 months to 5 years if hemoglobin is less than 11 we take it as anemia, or subsequently 6 to 12 years we take 12, and you males females, whether females are pregnant and non-pregnant, so there are different cutoffs, but actually it's a range and it all depends on the clinical background as far as the diagnosis is concerned, because many times the hemoglobin may be normal but the patient may be iron deficient, the patient may be symptomatic, even if the ferritin is low, the storage are getting low, patient may become symptomatic despite normal hemoglobin being normal. So it's a bit fallacious, but yes, it's a ready reckoner, so we should at least know at what age what cutoff to be taken. So we usually follow WHO. Hematocrit, yes, fixed ratio with HbA. I think this is also very common in pediatric practice rather than hematology practice. So in dengue, particularly in dengue, we use this parameter very often. If it is usually the hematocrit to hemoglobin ratio we should be is mostly around 3:1, because and that is particularly possible when RBC morphology is normal. If RBC morphology is normal, that 3:1 ratio may differ. Or like for example, dehydration, it may increase. Like there is a leakage, capillary leak. We know that it is disproportionately increased. Hematocrit to hemoglobin ratio increases. So, but in particularly in hematological point of view, if you see, it has been tried and used in alpha thalassemias, particularly where the hematocrit is to hemoglobin ratio is more than 3.5 rather than 3. Particularly, the many reasons have been hypothesized particular for that, like the hydration of alpha thalassemia cell is little bit more, and the presence of a lot of NRBCs. But yes, this is the commonly used the practices, like whether it is dehydrated or dilution. Then RBC count, we know RBC count low or high, both are important. High RBC count, particularly in pediatric age group, as we most of the times we have been reading in MBBS days polycythemia, but it is very rare. The genetic polycythemia vera, polycythemia vera is very rare in pediatric age group. It is particularly seen in adults with the JAK mutation, JAK2 or exon 2, 12 mutation. But in pediatric age group, as we see, when there is an increase in uh, RBC count, we have seen like congenital heart diseases, hypoxic states. So these are the things where most of the times RBC counts are higher. RBC count low, we all of us know if there is iron deficiency or other deficiencies, the RBC count may be low.
Coming to
Uh,
yeah.
yes, please, sir.
Yeah, basically coming to as relation to the RBC count, also coming to the indices of the RBCs, like I'm to say, many of the times we are just interested in the hemoglobin total count and platelet
Yeah.
count, while many times these indices are staring at us because we have got a huge load of nutritional anemia. So
Yes.
how closely we should be looking at these parameters, and what are the
Yes.
nuances in these parameters that, and can you just in short tell us about each of the parameter? What does it really signify?
Yeah. So these are the these are basically, if you are discussing about RBCs, these are the most important parameters along with that RDW. All these 3 plus RDW can help us make most of the diagnosis of anemias or whatever type of anemia. So MCV, we know that it is mean corpuscular volume, which measures the average average volume of a RBC. So it is usually from 80 to 100 femtoliters. And if it is decreased, like less than 80, or sometimes like from 50 to 80. So it depends on how much exactly is the MCV. If MCV is less than 80, we always go by most common notion in India, and we know most of the times it is iron deficiency anemia. But along with these indices, we have to see other parameters also. If MCV is low in one particular patient, for example, if child comes to us and MCV is 60 for that matter, looking at so everything has to be checked. MCHD is low, MCV is low, and platelet count is around 2 lakhs. So now we know that we have to correlate this finding always together, in particularly in iron deficiency anemia, which is the most common scenario in your case. We know most of the time these platelets are on higher side. But in India, it is just not the iron deficiency. Many times it's a nutritional anemia. It can be a combined deficiency and sometimes platelets. So it is not. So many times pediatricians or even our students ask, "Oh no, sir, we expect platelets to be on higher side in iron deficiency anemia." So it is not always the case. So every parameter has to be seen in correlation with all the other things. So low MCV iron deficiency anemia, if it's very low, so they have differentiated mild like thalassemias. If it is very low, for example, if MCV is 50, it still can be iron deficiency, but it is always prudent, particularly in a given set of given area, if the hemoglobinopathies is common, better to treat with iron deficiency. Many times we are not able to do iron profile in most of the patients. So in those patients, if you are giving a trial, always counsel them to come back after 3 months, and then you can yes get HPLC done. And it will not be prudent for all. Like if it's MCV, presenting MCV is around 60 or 70, you may not think of that. But yes, if it is very severe, significantly low MCV, always keep that in mind, because many patients are lost, and subsequently, even if they are just traits, but they can be a potential birth giver to a thalassemia major child, because still there is a social stigma and many people do not go for HPLC. MCHC, it is, I think, MCHC, most of the things we know, but MCHC, what we should remember is it is a measurement of corpuscular hemoglobin concentration, okay, in relation to the cell volume, which is more like usually is around 33, 35. Most of the textbooks give higher value of 36. So this is important because many patients come to us in OPD practice. We see MCHC of around 35 for that matter, which is normal. It is not very high, and but still, if it is borderline high, 35, 36, or 37 for that matter, always keep certain things in mind. Uh, so here it is spherocytosis. That is one of the commonest differential diagnosis. We can just pick up on the MCHC if it is really high. So there is a caveat. Not all hereditary spherocytosis will show MCHC to on higher side, but that is a matter of hematology. Subsequently, it's a atypical disease. It sometimes happens. But yes, if you pick up it is 37, always relook at the CBC, get it repeated, and if it is like that, we can think about hereditary spherocytosis. It can be even high in sickle cell disease and in other HBSC disease and all. MCH concentration. This is mean corpuscular hemoglobin. So it gives the value. These values we should roughly remember always they are always given in the control panel, but we should try to remember it is usually 22 to 23 picogram, and if it is more than 23 picogram, if it is higher side, we know that it can be a sign of megaloblastic anemia, not only MCV but MCH. MCH is also on higher side because the RBCs are less produced, and that is why this main corpuscular hemoglobin goes on increasing. So that can be a little bit on the higher side. High MCV, we know it's a megaloblastic, whether it is macrocytic, only megaloblastic, or non-megaloblastic macrocytic anemia. There are multiple causes, but our commonly what we see is B12 and folic acid deficiency. So these things can be picked up if it is higher, say more than 100. Look at other parameters. So I think this I would like to explain for a moment. So whenever you see MCV of 95 to 100 or more than 100 for that matter in a CBC, always look at other parameters because it's borderline. Many times we can miss. It is better to see look at the CBC, WBC count and platelets for that matter. If they're borderline low, WBC count of 3,500 or 4,000, so we know that there is a decrease in production of WBC. It's getting delayed, and platelets may be borderline low, early stages. And the other thing that we should look at is many times because these are missed. Even now, there is no reason why we should see patients in our OPD with platelet count of 35,000 and still megaloblastic missed. So if you see LFT, so there will be some indirect hyperbilirubinemia in those patients that can confirm that that is a corroborative finding because of ineffective erythropoiesis. There is a hemolysis, and hemoglobin, maybe indirect hemoglobin, maybe 2, 3, or 4 sometimes. So these are corroborative findings. So we cannot miss. We will not miss that at that point of time, and we can catch them early and treat them because as we know that if it is missed for long, whether iron deficiency or megaloblastic, there are a lot of deleterious side effects, even long-term effects on the child.
The important
Then
point for the
RDW,
office practice,
yes,
so important point for the office practice is that the patient may have come to you for some other reason, like maybe an infectious condition. But if you notice that these parameters, the indices are out of range, maybe you should make a second effort to find out why they are deranged. That is what
absolutely, sir.
Dr. Atish is the message is. And Atish, Dr. Atish, please, you can continue with the RDW interpretation of what is the RDW and what are those normograms? Can you please explain them? And I'll just
Yeah.
put up a graph also so that it becomes easier for you to explain it.
So I know rate cell distribution, which is a very fantastic parameter, which combined with all indices can give us the diagnosis of many things. So usually there are two methods to find out whether it is by standard deviation method or coefficient of variation method. Standard deviation method, we usually check the width of the histogram. If we plot RBCs and plot a histogram, width of the histogram at the 20th frequency, 20% of those cells. So if we can calculate, it comes around like 45 to 46 till normal. If it is more than that, we take it as a parameter to show that there is a high RDW, particularly anisocytosis. In RDW coefficient of variation, it is a mathematical in the analyzer. It is a mathematical mathematically it is calculated one standard deviation by MCV into 100, and I think this is most of the times this is what we practice more of. If it is more than 14.5 to 16, there are different people take differently, so it has to be correlated with other parameters as I discussed earlier also. So RDW alone, RDW will not give us many things, but if you can combine with MCV, high MCV, low MCV, or normal MCV, we can get a very good differential diagnosis. For example, many times patient comes to us with MCV of 95, and as we discussed earlier, and platelet count of 56,000, and WBC count of 3,000 with lymphocytosis. So it can be just megaloblastic anemia. And all of us know that mega B12 levels are very fallacious. Many times they are absolutely normal. So it is different. It is very difficult to make out sometimes. So very easy clinical clue whether it is aplastia. Severe aplastic anemia can occur. It may be moderate or mild to moderate severe aplastic anemia. So these things maybe missed if we overlook. So if you see RDW, if it is very high, so as in the case of megaloblastic anemia, we know different stages of maturation. So RDW is going to be higher on higher side. In aplastic anemia, it will be usually on the normal side. So we can at least have a clue. So these are not the diagnostic, but yes, it makes you think that no, we have something sinister at our hand. It is not just megaloblastic anemia. We should refer this case, or we should dig deeper. Let us get B12 folic acid levels, or get PS checked properly, because many times in megaloblastic hypersegmented neutrophils may not be seen, or they may be less than 3% at the cutoff value. So to have that idea, subsequent like low MCV also. If it is low MCV with high RW, we know it's iron deficiency anemia. Thalassemia trait, we know that it is usually in the normal range. Anemia of chronic disease, it can be both. It can be normal MCV with high RDW, or it may be, usually it is a normal RDW. So there are multiple permutations and combinations given the history of the child. If you put together these combinations, we can make most of the diagnosis.
So RDW is an indirect indicator of deranged indices, and the wider the RDW, the more attention you should be paying to it. Regarding to Dr. Atish, most important, what he wants to describe today is B for the white blood cell count. So what is white blood cell count? Total differential in short, can you tell us about it?
Yeah, so I think this is a so WBC count, we know total WBC count, everybody is aware of. Less than 1 year, it is little bit different. So compare, like total WBC count can be higher, but we accept absolute neutrophil count of 1,000 below 1 year. But after 1 year, it is mostly 1,500 and more absolute neutrophil count, and WBC count of 4,500 to 11,500. Some people take it as 12,500. So, but importance, yes. So importance of absolute counts, I think it cannot be overemphasized. Everything counts. So that is why we have a CBC. Every parameter, every cell in our body has something to do with some or other disease status. It is a presentation. Like for example, if you discuss about the different cells, we know granulocytes. They are granulocytes, non-granulocytes. So granulocytes, the neutrophils, basophils, and eosinophils. In non-granulocytes, lymphocytes and monocytes, they come under non, because they don't have granulocytes, monocytes also. So all these cells, when we check particularly in our WBC, and we get clue. For example, absolute neutrophil. This is the most important finding. Absolute neutrophil count. Whenever we in our busy practice also, we should always keep a watch on. At least see that absolute neutrophil count. It should not be missed. Many other things we may overlook, but absolute, because, for example, how these things are missed. If a patient comes like 4 to 6 months old child comes, and absolute the WBC count is normal, but absolute neutrophil count is just 500. So there are a lot of immunodeficiency disorders, or rather than going to immunodeficiency disorders, even common diseases. So where there can be lymphocytosis, there can be neutrophilia or neutropenia. There are a lot of disorders which we can make out. So if it is a absolute neutrophil count is increased, most commonly we know it's like some infections. We think that this is a infection, some particularly bacterial infection, where we see absolute neutrophil count increasing. Acute infection, particularly acute infection. Then lymphocytosis, viral infections. In initial stages of viral infections, there may be lymphocytosis. But this is very important to remember, lymphocytosis. In most of the patients, when patients presents to you with lymphocytosis, for example, a 5-year-old child comes to you with history of fever from 8 days. Initial cough cold was there 4 to 5 days. It is still there, but fever is still there. 100, 101, once or twice in a day. There are no other complaints other than weakness. Patient is not just fine. And if you look at the WBC, CBC count, hemoglobin is normal. WBC count is 3,500 with 70% lymphocytes, or 80% for that matter, and 15% neutrophils. At the 10th day or 9th day of fever, platelets of 150,000. So This is a very common scenario in viral infections. But if you really look at that picture, because we are hematologists, we always see 10 days of fever spikes in, although they are low grade, it is very unlikely in just viral infections. Many times there may be some sinister thing which is happening. So we should make it a point that if there is a lymphocytosis, always ask the parents to get one CBC done after maybe 5 or 7 days. Because many leukemias, many blood leukemias, particularly ALLs, they do not have peripheral blast. Or many times we ourselves, we do not ask PS of every child. We just ask CBC. It's not for everyone, but many pediatricians or general practitioners, they ask for CBC. So PS is not seen, or many times they usually report at a virally activated lymphocytes. Very difficult. I am telling this with experience. Lots of patients come to us with lymphocytosis, relative lymphocytosis, and ultimately they were leukemias, because almost 10% of the patients are like pancytopenic ALLs. They don't have much symptoms. They don't have much in the peripheral blood. They all blasts are sitting in the bone marrow. So if persistent lymphocytosis, it is just an example of absolute counts. Why we have to know? Other than if it is absolute lymphocyte count is very low, we can pick up many immunodeficiency disorders. Always see whether lymphocytes are really less, absolute counts or so. Even if we are not doing substrate analysis that we hematologists do or immunologists do, if particular patient is having multiple severe, persistent, unusual, or recurrent infections and absolute lymphocyte count is very low, so it can be a evidence for immunodeficiency disorders. Likewise, there are other basophilia, eosinophilia. All these points towards something. Like particularly if you talk about eosinophilia, we know eosinophilia is mostly seen in allergic diathesis, many parasitic infestation or other skin infection. If you go sinisterly, sometimes in some sorts of leukemia also, eosinophil counts are high. If you go post-transplant, we see in GVH, if there's a graft versus host disease post-transplant, we have eosinophilia. So these absolute counts of all the parameters are important in everywhere, not only in common pediatric practice to the high-end transplant point of view also. So lymphocytes, basophilia is a very important thing. If it is a higher, basophils are persistently high. Yes, they can be there in like eosinophilia, basophilia can be seen in allergic diathesis, Crohn's disease, or other immunological disorders. But sometimes it can be a part of chronic leukemias also. So the higher basophil count can be seen if there is spleen. Basophils are there. There may not be blast. PS may not, the CML PS is not picked up many times by normal pathologists. So it can be a sinister thing. So always better to have whatever flags are being shown. I think next question is about IT ratio. I think this you people are more aware than me, because this is mostly used in neonatal practice, particularly in early onset neonatal sepsis. I think if the ratio is more than 0.2, there are a lot of studies to predict whether if the image IT ratio is more, whether it can the chances of sepsis. There are studies to prove that if IT ratio was more than 0.2 and the culture positivity rate in that particular group were high. Band forms also, I think, one of the same thing, but it needs mention because band forms can be seen in normally also. So they are usually less than 10%. Some there are different. If you go in details of band forms, less than 3%, 3 to 6 and 16, more than 10 is definitely increasing the it is called as bandemia, and it can be seen. It can be seen in particularly initially in infections. The band forms are increased to significant extent, mean there is some infections going on there.
So Dr. Atish, regarding the band forms,
Yes, sir.
many times we are reported with 3% band forms, and so that should not really alarm us. 10% band forms or more should really be one of the things that we should be looking out for
Yes,
as a
sir,
baby.
absolutely.
And basophils, you have already spoken about the basophils. So regarding the cytopenias versus cytosis, what were the cutoff values for their counts in either direction, which you have already told that lymphopenias and other conditions and lymphocytosis. Does hypersegmentation of neutrophils have any significance in the smear?
Yeah, absolutely. This is, I think we discussed. So hypersegmentation of neutrophils is very important. many times, because if you can pick it up, most of the times, six or more, six lobes of nucleus of neutrophils, it's significant. If it is less than six lobes, like five or more, five lobes, then you need at least 3%. Some people say 3%, some say more than 5%. We can take it as a evidence for uh, megaloblastic anemia. That is one of the important things, and it should be seen in the PS. It is a very easily seen. It usually happens because these RBCs are their aging RBCs in megaloblastic anemia. They do not die initially, and they so as a aging. It specifically it usually shows aging. But yes.
What is really a pathological eosinophilia significant count? Like I'm saying,
So
many times
here also in
percentile.
So eosinophilia also there are two cutoffs. Some studies have used more than 500, but most of the times we should see that if it is like absolute eosinophil count of more than 500, we should take it as significant. Some people or some studies have used 1.5, like 1,500 also. So we should always take, if it is more than 500, we should get alarmed. Initially think about the common conditions, parasitic infestation, they are the most common causes. Treat it. But some studies have thought that it is eosinophilia is not a one-time measurement. If it is persistent for 4 weeks, at least check twice, then they call it as a proper eosinophilia. And we should always look for, like for example, if I see a patient of eosinophilia of 5%, I will give some albendazole, and if the patient doesn't have any other complaint. But if he comes back with the same thing, always check other things like other common skin allergies, or other allergic diathesis or autoimmune diseases for that matter. So it has to be kept in mind.
Regarding monocytosis, we know that low monocyte counts are usually seen in enteric fever, but any particular conditions where monocytosis will alarm you?
Absolutely, sir. Monocytosis, infectious mononucleosis. So there are some viral infections where monocytosis is commonly seen initially. But there are other things also where other infections, viral infections, particularly where monocytosis is seen. And most importantly, it is not just the viral infection. There can be some sinister things also that we deal. It can be a monocytic leukemia, or it can be a CML where monocytic count can be higher side. So if it is persistently there, it is better to cross check whether really they are monocytes or they are monoblasts. It is difficult to make it for a normal pathologist. So but there are monocytic leukemias, so we have to check for that.
Regarding the most looked at count in during the infectious season, the platelet count. When do you order a manual platelet count? Usually when you see a low count.
Yeah. So this is very important point. I think when many times patients come to us with platelet count of 50,000 or 11 lakhs, and they are, when looking at them, we feel that, oh, this looks like abnormal. This may not be correct, because many times what happens while measuring platelet, because sometimes the Coulter takes fragmented small RBCs as platelet count and show that it is very high. Sometimes platelets are stuck together, they are giant platelets, and the platelet count is curiously very low. So if you suspect, if the patient comes to you with platelet count of 17,000, no bleeding, absolutely normal looking, everything looks bang normal, you should always ask for a manual platelet count, because platelet count is one of the most important parameter, which is many times it is mistakenly calculated by even the current automated analyzers. So it has to be whether there are
Regarding
giant
the platelet
platelet.
indices, like pediatricians are mostly not aware of the implementation.
Yes.
Yeah.
So platelet crit, it is just like hematocrit. We know some platelet crit. It is the how the volume of platelets, how many platelets are there. Mean platelet volume is most important out of these parameters till now. So although platelet crit has been studied with many other like appendicitis and all, it will be on higher side. But they are hypothesized. But my platelet volume is most important parameter here. We should be knowing about it. Many times, as I told you, MPV is very, like, many filters or many normal pathology lab, they do not mention about MPW, MPV. A child presenting with 1 year child comes to you with some allergic diathesis, and a platelet count of maybe 80,000 or 90,000. And if you fail to look at that MPV, you may miss a Wiskott-Aldrich syndrome. If MPV is less than, the most of the times it is like more than 7.2, we call it as normal, less than 7, along with some other history. But I told one thing previously, because I have seen many Coulters where MPV of 5 and everything was normal. So they should be standardized. So always ask your pathology lab whether they are calibrated parameters, because then only the value, there is a value to that parameter. So MPV, if it is less than 7 with other parameters, we should not miss MPV, Wiskott-Aldrich syndrome. Similarly, if it is very high MPV, more than 12, 13, so there are, that means there are giant platelets. Giant platelets, we know they can be there in even in single small the ITP. If there are a lot of giant platelets, we know the patient is not going to bleed clinically. If it is more than the MPV is always on higher side and thrombocytopenia, look for other disorders, platelet dysfunction disorders like Bernard-Soulier syndrome, Meigs anomaly, Pearson syndrome. There are gray platelet. There are syndromes which with platelet the platelet size is on higher side, MPV is more. So unless you see that, it will be difficult to predict, because these patients do not, Bernard-Soulier syndrome, many patients do not present early. They have some sometimes epistaxis, sometimes bruises, and we usually miss them.
Which clinical setting should these indices warrant a closer attention? You already told that.
I
My
think
particular question is regarding dengue. Like I'm just saying, we get many times
yes,
low platelet counts. What
yes,
is the
sir.
marker in the peripheral smear that the platelets are about to recover? Do you get any particular signs in the peripheral smear about the platelets?
Yes, sir. Like if there are large platelets, basically when there is a formation. So as we know, dengue thrombocytopenia is still a debate. So there are two hypotheses which are put forth. One is peripheral destruction, and second is there may be some mild suppression. So, peripheral smear, if whenever there are new formation of any cell line for that matter, it is like new bigger things, reticulocyte in RBC parameter in platelet, large platelets. If you are able to see large platelets, immature platelets, then these immature platelets, if they are coming in periphery, they are like that means that the recovery is about to happen. And most importantly, I think immature platelet fraction that has been very well validated now. I think 5 to 6 years back, we always used to talk about immature platelet fraction, how important it will be. It will be a game changer, because many times we get an idea. Oh, this is always a confusion, still not solved. Like dengue patient with 10,000 platelets, whether to transfuse platelets. Some hematologists will say don't transfuse, some will say transfuse. So we should have some idea. So I think we can always take help of immature platelet fraction. If it is very high, on the higher side, more than 10, 12, then we can just wait. I think that's a clinical background. But yes, it always comes with the other parameters, whether the other coagulation parameters are absolutely normal. So we have to mix and match things and then take a call. So immature platelets in peripheral smear is a suggestion that no, these things will come up fast.
The most important part for and a favorite of the hemato-oncologists is the peripheral smear. Tell us something about the importance of peripheral smear, and is it always a good practice to have a look at the PS report in
Yes,
addition to
sir.
the CBC?
So being hematologist, we are always biased. We think that it should PS should be seen, because many things are missed in the Coulter report. Not because the Coulters are not because it is not a problem of pathologists, but many times many hospitals, they don't have very good Coulters. Not many times they are not very well calibrated. So I think PS is important, because taking a call only on Coulter report for particular value or particular differential diagnosis is a we have seen multiple times that many this platelet, as I discussed, platelet, not only platelets, other parameters also are misleading, and peripheral smear is most important. Even blast, there is the large cell ratio, it's mentioned in the Coulter, but the monocytes are picked up as a large cells. Obviously they may be just normal, but whether this LCR is a abnormal cell or not, that cannot be differentiated by even the recent Coulters. We have to have that idea. Well, because we are not doing flow cytometry for all the parameters there. Those can be picked up in the flow cytometer. If you are using flow 3-color or 5-color or 7-color, 5-color flow cytometry, in those we can definitely pick up oh, these are the CD markers, and this is not a monocyte, this is a monoblast, or similarly like that. So PS is most important. I will advise PS. Obviously, when you require a CBC, then only you advise a PS. Most of the OPD practice, we do not require even CBC. But yes, if you suspect, better to get it reported along with PS, because it is another, it is another point to make sure that pathologist is seeing the CBC. Many times, well, as we know, many times we see that report is, may not be seen. Many times technicians also report CBC. PS, if you're right, it has to be seen by a pathologist. So that is an additional advantage, logistically.
No discussion would have been complete without a peripheral smear. We are running a little bit out of time. So two or three, one particular clinical situation, 3-year-old female child comes to OPD with complaints of constipation, predominantly fed cow's milk feeding. The CBC is in front of you with the indices and the peripheral smear indicating microcytosis, hypochromasia. It's a spot for anybody, but can you elaborate what you're seeing quickly? And then I think we go on to questions. And
so I think, it is very clear. The diagnosis is very clear. So I think the advice should be, it is very common, particularly in our Vidarbha region. Most of the children are feeding like 1 liter of milk in a day, most, and they are definitely iron deficient. So I don't know. So the what Nielsen says, less than 5 to 600 ml of milk should not be fed, or even we hematologists, we do not prefer cow milk at all. It should not be given according to us. But yes, it has a lot of other nutrients, so should be given in appropriate quantity.
Moderation. Yeah. Second scenario, again, a 10-year-old child complains of malaise, premature gray hair stands with the particular type of a CBC, which shows the indices to be on the higher side with a dysmorphic type of a peripheral smear with hypersegmented neutrophils. What other investigation will you order in this situation?
So I think this we discussed. If there are hypersegmented neutrophils, and we are very sure, the most important thing, the investigations will be advised depending on what history we have taken. It is all, this megaloblastic anemia is a history diagnosis. If whatever dietary history you take for drug history, most all other histories, because we should not miss some causes of other things also. So considering 10-year-old with this must be nutritional B12 or folic acid deficiency, most predominantly folic B12 that we see in our practice. One clue I want to give in this is, like, if you don't see hypersegmented neutrophils and MCV is very high, like 130, so always think about other diseases also, like autoimmune diseases, SLE with autoimmunity, and this is missed. Many times our patients have come to me with MCV of 130 and they're being treated with B12 and folic acid. So, but DCT was not done, but in that case, so many times they can be autoimmune hemolytic anemias. So they may not be, so no, all autoimmune hemolytic anemias do not present like suddenly hemoglobin of 3 and 4. They can present slowly. They can exactly present like this. But yes, obviously hypersegmented neutrophils will not be there. There what will be there is, maybe there may be some microspirocytes or so in PS, or fragmented cells for that matter, hemolytic parameters.
Last clinical situation most commonly encountered with a high hematocrit and high hemoglobin and low platelet count. The
I think
obvious
this is
diagnosis
also
that
pediatrician's domain. So this looks like viral the high grade fever 3 days with hemoglobin of 16%. In our, particularly in with our area, this looks like dengue or dengue like illness. So further parameters, platelets, I think this is IPF, immature platelet fraction, is one important thing, particularly when if the platelets are not, it is not indicated in all the patients. If we are not seeing the recovery of patients, recovery of platelets, it is taking long. So this, I would like to take one more minute on this, because this is a scenario. So platelets can be low in dengue because of three reasons. So we hematologists call it as a triphasic fever rather than biphasic. We know it is a biphasic fever. There may be borderline cytopenias, platelets recover, fever disappears and then again comes. But if there is a persistent fever in dengue syndrome, we know more. You must have intensivists must have seen, if fever is persistent, the splenomegaly which had regressed is coming up again. We have to think about the secondary HLH. We have seen in many patients of dengue in Gangaram Hospital. We have published also. So a lot of patients can go for HLH. So, but we should not think about directly HLH. We always take opinion of specialists for that. But it happens because even if it is a secondary HLH, we may have to give dexamethasone. So before that, we have to do all the parameters, prove it, and then treat. So platelets remaining low or platelets coming up and again going down has a different meaning altogether. So if it is persistently low, do a IPF, see whether it is high or low. High means yes, between next 2 to 3 days, platelets are going to jump up because in clinical practice we know as we expect that platelets, but many times in dengue we have seen. And the third thing what we have seen is post dengue ITP also. Platelets recovered, and after 2 to 3 weeks, platelets went down. So at that time, it may not be HLH, it may be ITP. It is very common. It is commonly seen post dengue ITP. So
Thanks, Dr. Atish. You have really covered the topic and the subject thoroughly for us to understand the importance of CPC in office practice. Any quick questions? And I think then we can conclude. Anybody has any questions? So, Dr. Grivita, can I proceed with the
Yes.
to conclude the session? Dr. Ram, you want to add anything?
Yes. You can proceed to conclude the session.
Yeah. So I thank all the speakers today all the experts who have come today, all the dignitaries from the Maharashtra IIP who have been a part of this program, and my co-moderator, Dr. Grivita, and all of you, most important, Dr. Pustake, who was our observer, and Dr. Atul Kulkarni and Dr. Amol Pawar, who always have taken interest in all the programs that are being conducted, and all our dear participants, our dear Maha IPNs who show so much interest that we are really privileged to bring you these programs. With this, I thank everybody and conclude the first episode of Tips for Office Practice today. And let's meet again next month.
thank you so much, sir.
Thank you.
Thank you.
Thanks, Dr. Atish.
Thank you,
Thanks,
sir.
Dr. Ratna.
Yeah.